You dim down the light. Start with the neurovascular trauma. I always show the diagram of mechanism of traumatic vascular wall. If you have hit injured to a vessel, it can start with a typical subintimal dissection. Rarely it can also be a subadventitial dissection that's still normal lumen, and it can progress into the dissecting aneurysm with the inflow and outflow type, what you call dissecting aneurysm. And if all the layers of the wall are injured, you are dealing with either false or pseudo-aneurysm, or if you have some injury to the nearby vein, you're going to have the arteriovenous fistula. Usually people call traumatic aneurysm, it can be the combination between the dissecting aneurysm and false aneurysm. You just can see in many examples later on. So lately there are some grading system which seems not to explain something more from the diagram that I showed you. So what could be the outcome of traumatic vascularization? The lumen can be narrow and occluded, both artery and veins. It can rupture both artery and veins. It can create mass effect, especially if the time of chronicity comes. It can present with a mass effect. It can, of course, be emboli, can be arteriovenous fistula, either extracranial in the higher drainage, depends. For the venous side, you can have the venous thrombosis. What I try to write here is that if you have the base skull in between extracranial and intracranial or the dural, you have the base skull at the middle. So usually the vessels are shown there, and what I write here is the common pathology down to relatively uncommon in terms of each level. From the base skull, you may have, for example, arteriovenous fistula as the most common type of pathology, where in other part you switch between the most common form at the top down. This is what we expose, and time is very important. You need to check the acute, subacute, and chronic. For us, we have the most common form at the base skull, and I'm sure we are talking the same between countries in probably have a lot of motorcycle or car accidents. We will present with this as the most common form. We were looking the first 15 years of our series that we have most common form, 80% becoming a traumatic CC fistula and a traumatic aneurysm, and then later on down. If I count the next 13 years, we dropped down a lot for the traumatic CC fistula. I mean, the reason one is that we train enough people to all over the country so that in our institute we have less traumatic CC. We have trained northern, southern, northeastern, so we can treat the patient themselves well. So this is a slide that I show you from the dissecting aneurysmal vasculopathy. If we add traumatic as the cause, then the reaction will be the same. Dissecting traumatic aneurysmal vasculopathy can be repaired, can be scarring, it can be evolutive and persist, and it can be recurred. Example of this big CC fistula at the base skull, with looking at the cervical area, you know that that is the same trauma created this dissection. We were able to treat the fistula upstream, and because we believe that this is no symptoms related to the lower down dissection, and we were able to follow up to 5 years. Seems not definitely changed, a little bit smaller, flattening, but the shape would be like that, and it repaired heal in that shape. However, the common decision is that the abrupt occluded, and we were having this related to the trauma, history of neck trauma, and there is odontoid fracture there, and the dissection was seen lower down, and this is the more common type of dissection that you have occluded. We don't do anything with this neck pain symptoms. In the opposite, same trauma at the region, you will see that they put the operative screw at the area of upper cervical level, and there was the irregularity of the vertebral artery by that time. And over the time, we see this pouch along with the area of previous irregularity. This is the thing that the dissection can be seen, and it needs to be treated by that time. So usually medication to prevent the thromboembolic can be discussed, and the treatment, I'm not much into acute stenting in a traumatic dissection, because we know that multi-trauma are very common in the region. So if you want to put a stent and put double antiplatelet, be careful of the bleeding from the other part of the injury. For example, surgical intervention can be one of the discussion. For that growing pouch case, we made decision to sacrifice because the bleeding seems endless from the surgical wound of the operation. So checking all the possibility of contralateral, vertebral, and collateral to sacrifice is the easy ways. Stent placement can be one of the option in the reflex stroke case despite medication. And for this case, they were putting 2 wall stents, and even a little dimming immediately there. If you follow up, usually it's healed. Working in Vietnam with the team, we were having this 5 years after trauma and the neck mass there with the pulsate height and recurring stroke. So no doubt we have indication to treat, and by that time the team was putting stents and coils. So we come from the dissection to false aneurysm by location. Again, it could be intracranial or it can be extradural or interdural. So the most common false aneurysm is still at the base skull, whereas the relationship with the intracranial, it could be relationship with the fixed structure, for example, the false cerebri and the tentorium. There are typical pathological pictures showing how false or pseudoaneurysm are. You can see that there are rupture of the entire wall. So at the collection of contrast, you have no wall. So imagine you inject too strong or you put material inside the false aneurysm sac. You can easily rupture it and just put it without the wall there. So think about this pathology. Let's remind you that there are angiographically picture of the false aneurysm from other type of aneurysm, that you have delay filling and emptying of the sac. You can still see this until the venous phase there, and the shape is usually irregular and usually wide neck or absence of the neck. That could be the difference between the regular aneurysm and this traumatic false aneurysm. Naturally, see it is bad. There could be the catastrophic rupture, which very high mortality. So usually when you see, it's already symptomatic, and most of the symptoms are hemorrhagic symptoms. The usual one, when we pass anatomy, we know that there are variation of this so-called aberrant cause. pseudo-internal carotid artery, which actually is a persistent stadial artery, and it can be misdiagnosed in the ENT examination to be a reddish mass, and some has been biopsy created this false aneurysm. With this gunshot wound at the neck, you can have the same broad-based irregular type of traumatic aneurysm, and for this case, the surgical reconstruction has been done nicely. Chronic times come with the size. So with this gigantic, we were working, get this up this in middle of here, that this is his case that he's been doing here with this gigantic pulsating mass from the trauma about 10 years ago. And look at how this can be seen over the time. And for sure, this is the telescopic stent that we put and treat the patient. And this is the result of the treatment. And you are able to put maximum more in terms of chronic case, because you are not, you think the vascular wall become a little bit stronger, both artery and venous, if there are venous injury. Vertebral artery can have this traumatic aneurysm. We were seeing mostly in the iatrogenic operative side. This guy was having the spondylosis, and the treatment of fusion, etc. was done, and there are bleeding immediate after operation that they cannot stop. And you were seeing that at the site of operation, you see this traumatic aneurysm. We were able to challenging to just put nicely the coil. We're having a chance to follow up and just helping the healing system. It worked in this case. External carotid artery, if you have the fourth facial injury, the bleeding comes on the nose, when some back to the throat and come out from the mouth. Usually you check for this type of the intermaxillary artery, and there are big false nerves in there, and they put proximal embolization. Just usually proximal is enough for this false traumatic aneurysm, compared to just putting everything in the sac without the wall, can be imagined. So the current treatment is still occlusion of the main artery. You can try to go close to the aneurysm, but I don't recommend to go inside the aneurysm. So even just super selective micro catheter and push hard, you can rupture already. The gunshot wound through the mandible with a communicating fracture over the area, the massive bleeding per mouth. And sometimes you need to look carefully. The injured vessel may not be a big contrast collecting area. It can be just one missing artery. If you have the missing artery, it can be the point that vessel is severely injured. Okay, we have just a little dimple to show that it's still there, but it's traumatized. And again, by careful analysis of this angiogram, and you were able to target your treatment. Okay, of course, we help the patient. Post-operative tumor at the skull base, bleeding intraoperative and cannot stop. It's good to have the global common carotid injection before you go into both. In this area, you may notice a little tiny unusual collection, and you were able to see, you see a little tiny branch going over there with this collection of the contrast. And if you were able to go super selectively, and a drop of glue can help the situation. And this is post-op. Angio, no more dot at the area that coordinate well with the bleeding and the operating site. How about more distal? The distal one can be related, as I told you, false cerebri. And No doubt the bleeding there related to this, artery that have the movement, strong movement related there with this aneurysm is shown a little bit distal than the usual aneurysm. Also, left foci, you have this edge of tent, and you can have also the aneurysm of the area that can relate it to the traumatic type of aneurysm. And with this first the trauma, you see subdural collection, a little bit subarachnoid intraparenchymal classic for the traumatic brain, and you don't see anything much, but later on with this, you can see develop and the region of the trauma that is related to blood vessel of the region. We were having this massive subarachnoid hemorrhage, which is a little bit focal, more focal subarachnoid collection at the two areas and the dot enhancing within the blood. That for sure you can typically see the classic angiographic finding of the aneurysm that lasts until venous phase. We treat the patient. And now we come to the base of skull. I told you that probably the commonest part or petrous part, you can have these symptoms of the mass or hemorrhage. So when we were high cervical and petrous, you can have this type of the false aneurysm that was shown there with a massive bleeding. For example, the angiogram could be like this. This is the same case. So how about this aneurysm and what about the natural history? It can enlarge and produce Cone sinus syndrome. It can rupture to be traumatic CC fistula. It can rupture into the sphenoid sinus, causing massive epistaxis. And in the above cavernous, if you have the dural tear at the region, you can have the leakage with the subarachnoid hemorrhage. Size can be along with the time. For example, this large one, because of the long time injury, of course, the Cone sinus syndrome will be seen. Compared to day one post-trauma in very hyperacute phase, you may have this tiny little, fistula that was seen, shaky finding of the leakage of the blood. Whereas in the later phase, you may have growing and becoming the classic type of the CC fistula. Of course, you were able to treat nicely. And the last one is like this, eroding the base skull. Eroding the base skull with vascular, high flow vascular structure. You can have this bone eroded, whereas you can have, the pouch extended above the dura. There are risks of subarachnoid hemorrhage in that case, and there are risks of intrasphenoid sinus false aneurysm that can bring you to massive epistaxis. Traumatic vertebral fistula can be seen. It usually can be any level, even more common at the upper level, but you can have these classic type chronic one, like this becoming a large vertebral artery on the left side, or with this, collateral filling down to the injured fistula's location. You know where is the location. You can put embolic material as close as possible to the arterial root, and you were able to reconstruct nicely the vertebral artery. Decision making is very important. You need to aim to cure. If you were able to, keep the parent artery is good. So better check collateral in case you cannot keep the parent artery. Chance of preserving the vertebral artery is less than in CC fistula. Interestingly, there are roles of spontaneous healing in traumatic vascular injury. I have collected not only dissection, not only dissecting aneurysm, but false aneurysm in some case. When you don't treat it at the beginning, you may have seen the spontaneous healing approach. Even a slow flow arteriovenous fistula can be seen. Here I was putting this cross-sectional study to see how the healing process over the time and get the preservation of the lumen. And you were having this transsphenoidal injury to the petrous internal carotid. During being outside our hospital, before sending to us 2 weeks, nursing become more defined, smaller, and at the follow-up, better defined, smaller. So it can be seen with this false aneurysm. It doesn't mean that you need to wait. Depends on the symptoms and the time you get the patient. Dissection here, without treatment, can be here. So this can be seen in any type of injury because we expect the original vascular wall is healthy. Usually you have injury in younger age group because a lot of activities and driving. So seeing these ugly looking traumatic aneurysm and the healing process in the follow-up can be seen like this. We were having this relaxed case which kindly give the example to us bilateral ugly looking fistulas at the common sinus. They were able to bring the patient to be treated. This is when they bring the patient to be treated without treatment. So it can happen, and this is, I don't know how many days, it's within 1 month. So it's up to 2-3% of being able to spontaneous closure. So very important that the time to evaluate therapeutic evaluation is there, and it was like injury, either hematoma, hemorrhage for dissecting aneurysm, especially hemorrhage to the organ space. Upper part, subarachnoid hemorrhage, lower parts, your nose, your mouth, your wound. So that is things that you need to see and try to look at the patient as the overall associated injury. Look at the ventilation, the normal routine in the emergency room. So what I would say that is better, you have more time in subacute to chronic stage. That now dissection will bring you to ischemia, thromboembolic, and AV fistula may present to you with the venous drainage symptoms, and you have time to think. So for the first part, my conclusion is that neurovascular trauma, clinical approach, symptoms in acute, subacute, and chronic phase are very important. Proper diagnosis should be fast, effective, less aggressive, less repetition. Do know people can move by that time of the clinical. Don't expect very beautiful, nice images from CT or whatever. So ready to treatment decision, either medical, endovascular, surgical. Keep in mind that there are tiny role of spontaneous healing to 3% of all traumatic vascular lesion, but based on coming from the normal vessel, but depends on the clinical you expose at that time. And no need to exact luminal shape preservation is from our role. Multi-trauma are frequent, set priority of lesion to be treated. So thank you. This is the first part.